Hello, everybody, and welcome to the Doctors of Running podcast, where we, a group of doctors of physical therapy, discuss the art and science of running and the stuff that we put on our feet. Today at the round table are two people, the founder of Doctors of Running, Dr. Matthew Klein. I feel like I'm saying doctor about 50 times right now. And myself, I'm Nathan Brown, and I will also be here. Today, we get to have another conversation about one of the more common running-related injuries, and I would say one of the more misunderstood running-related injuries, particularly in how to manage it, and that is IT band syndrome or iliotibial tract syndrome. So we are excited to dive into the anatomy of this region and then some of the ways that conservative management is considered, factors that can actually help, other factors that maybe won't be as helpful, and a lot of the gray area, because there is a lot of gray area with treating this condition, particularly with prognosis, meaning how long is it going to take for me to get back to running without any pain. But before we get into that, a couple things that we just wanted to touch on. Matt, you are testing a couple of new shoes right now. One of them that we were going to have you talk about is a trainer, and the other one is more of a racing shoe. Which one do you want to start with?
Let's start with the trainer. So that's always a good place to start in general. And slightly off topic, but to defend you, because it's you're like, oh, it feels like I'm saying doctor like 1,000 times. To be fair, in not too long of a period, the two of us are going to have 4 doctorate degrees between us. So good luck to Nathan.
It's almost embarrassing.
Yeah, it's always okay. I mean, that's what it takes for us to go and teach in academia now as PTs, but yeah, it's a different story. But yeah, I just want to wish you good luck with your station events. Although by the time this comes out, that might be happening
right around this time, actually. Yeah. Maybe even day of.
Yeah. So everybody send Nathan,
or the week after. Doesn't matter.
They're good thoughts. Although it's a good time. The dissertation defense, I hope that you have a good one. I hope that it's fruitful and it is a good experience for you.
Something I appreciate about the program I'm in is that they say upfront that they want the dissertation to feel like a celebration, where it's not so much you having to just prove your chops and prove your worth. It's more, you've put in a ton of work. You've done a lot of learning. You've done this study. You've worked really hard. Let's show off all the stuff that this team of people has done. So I do appreciate that that's the kind of posturing of the program. And I think it provides an opportunity for some really fruitful discussion instead of defensive discussion. Do you know what I mean?
That's really nice. That's not how mine was. Mine was like, my advisors were like, yeah, we've already ripped you apart. We don't have that many questions. We're going to bring in some other people who don't know biomechanics as well. And then I went from being defensive to offensive. Not like I'm telling inappropriate jokes, but I was like, oh, so you don't understand this. Well, let me explain this to you. And so it was very still intense. So I've always been very happy. So Nathan's always talked to me about this. Sounds like a very supportive program, which you never know what you get.
You never know. Mm-hmm.
So I'm very happy for you, and early congratulations. Hopefully that's not too early.
Yeah,
but yeah.
I've been super thankful for my committee chair and my committee. They're just great people. And then, as you know, working full-time job, also getting another round of school done, like having Jana and Henry and Ray, they've just been super amazing the whole way and super supportive, and thankful for other family who's come in and helped us out along the way, because it's quite the lift, but it's honestly been so fun. I know that the whole route of dissertation work isn't always clean and a joy, but I have overall really enjoyed the process, learned a ton, and learned how much I still have to learn. Which is fun. And sorry to everybody, like Matt's dissertation came out and it was like, hey, here's some really cool things we can think about the Achilles. Sorry, mine has nothing to do with running. Mine is really looking at health outcomes in rural communities in Wisconsin and the roles of physical therapists there. So I think it's super interesting. I don't think people who follow Doctors of Running are necessarily going to can't wait to read the dissertation. So I apologize for that.
To be fair, I also geek on that as someone who's also in the process of kind of getting into primary care in rural areas here in Oregon. So I geek out about it, but we'll have some stuff waiting and ready to go. So don't worry. We'll have plenty of other stuff for people to geek out on.
Absolutely.
But, sweet. All right.
Let's talk about the Cumulus.
Let's talk about the Cumulus. I'm going to take that off. I got to take that off topic and wish you good luck. So previous Cumulus, this is the version 27, which blows my mind to realize this shoe's been around for that long. It's, again, one of those, I would almost call it like a legacy shoe, where it was around back when many of us were younger and working in running stores, and it's still around. It looks very different than what it did for sure, just as the Nimbus does. But this is, I would call this Asics standard daily neutral running shoe, although it's not fully neutral. It's a different story, but it's a solid shoe. It's one of the fewer shoes now, especially even in the Asics lineup, that's under 40 millimeters, although Running Warehouse is giving some slightly different stack height measurements on that. It's a good standard. I'm not going to say boring, but just a good consistent shoe, like a really great shoe for newer runners. The foam is slightly softer without being mushy. And it's just got a ton of, there's pure gel in the heel, Flight Foam Blast Plus. And it's got this really interesting outsole where it's like supposed to be an outsole, but it's kind of not. And the last version I hated. There was just so much aggressive toe spring. It felt short. It just wrecked. My toes got wrecked and the fit was really, really off. So I did the best I could do to get miles despite some blisters. And I was like, nah, even though it's supposed to be an upper update, they did a lot of changes. The toe spring is noticeably lower, fits much, much better. Because the toe spring's lower, the forefoot is just a teeny bit stiffer. Sidewalls feel more prominent, or maybe I just could notice them more in the heel, but it's really a good, solid, consistent shoe. Like, it's not fancy. It's not a super foam. It's not crazy. The durability is a little, as you can see, for those on YouTube, you can see I'm ripping through this. So durability is not hot with this. And I want to ask Nathan about this second. It's like a exposed midsole /
it's like
outsole.
A rubberized EVA, I'm guessing.
Yeah.
I don't know the specifics on the material. So if somebody does, let us know.
Yeah.
But it reminded me back, I don't know, 4 years ago or so when the first Carbon X came out. They used a rubberized EVA outsole. And then that was also the Mach X series until the Mach series. Until they got to the Mach 6, they added rubber to the outsole, which made it one of my favorite, in my favorite Mach to date. They also changed the foam a lot, but I appreciate having, for a workhorse trainer or a daily trainer, having rubber on the outsole just makes a lot of sense to me. And the fact that this is just a rubberized EVA, I think, is a shortcoming of the shoe. I have been able to run a little bit in that shoe on the treadmill. I haven't taken it outside because there's still like snow. And if there's ever snow and there's no rubber, there's no grip at all. So it's not even worth me trying. Should melt in the next couple of days because it's been like almost 60 degrees.
Wow.
It's been amazing.
That's
and awesome. So I think that's a shortcoming of the shoe still, is the decision to have it as a kind of rubberized foam of some kind, or some kind of toughened foam on the outside to make the outsole, because you're just missing out on some durability. My question for you is, if you had to choose between that shoe, the Cumulus, and the Trinusa, which shoe are you picking? Because the Trinusa is $135. That one's $140. And I would say, I believe there's a lot of similarities between the two shoes. Which one are you picking?
It will. So are we just talking in general, or are we talking for a specific purpose? Ooh. That's going to be hard. Ooh. I'm going to have to say, yeah, you stumped me. You got me really, really good. So that is really hard because I love lightweight trainers. So there's a little bit of bias toward the Trinusa, but I am actually really enjoyed the simple ride of this, and the fact that the heel is like really nicely stable. And they did a really good job adding a slightly posterolateral heel bevel here, which is not super common for Asics or anybody. So that's been a really nice touch. And the fact that it's really simple. The durability also makes it closer because the Trinusa has much better outsole durability than this. But I'm going to have to go with the Cumulus 27 on this because of the versatility into being a little bit more cushioned. I've done everything in this already. I've done a workout. I just did a long run this morning. I've done several easy runs in this shoe. It's not a super fast shoe, but it's definitely on the lighter end for daily trainers. And I've done a workout. It's fine. It's not the fastest shoe, but for kind of where I am at this point in my life, where I just want a standard daily trainer a lot of the times, I'm going to probably pick the Cumulus. And the change in the forefoot and the rocker profile, it really, really made it a lot better. Just know it's very stiff initially. So yeah, I think it's not running nearly as fast right now. This, if I was in my speedier era, then maybe it would be the Trinusa. But I think the update here is very, very good, although we still got to work on that durability.
Yeah. Well, that's surprising. I'm a hands down Trinusa person because I think a lot of what you like about the Cumulus is what I like about the Noosas.
Interesting.
The simplicity of it. It's not a fancy foam. It's got a mild semi-rigid but semi-flexible kind of forefoot that has a slight rocker. The toe spring's not too crazy. I agree with you. They improved the toe spring on the 27 as well. It's not as noticeable as the previous version. So because it has rubber and because it's $5 cheaper, and I think the upper is hard to beat for the Tri-Noosa, I go that way. But I also don't need as much structure through the heel as you do. So I can see why you verge that way a little bit.
Yep.
What's the other shoe?
That was a tough question, by the way. That was a really good one. Yes.
What's your other shoe that you've been testing, the racing shoe?
So it's the Diadora Gara Carbon 2, which I did not test the original one. Andrea did, but I was really excited to get this on my feet, and it's very different. It is not kind of in traditional line with a lot of super shoes, although it's got the factors you need. It's got the super foam, PX foam. Is that right? PBX foam. It's got a carbon plate in there. It's a little lower drop, so it's 5mm drop, and then there is a full length carbon fiber plate, obviously, to top things off. I was very interested in this. I'd never tried it before. Some people had said the previous version was stable. It's not stable really at all. I can run decent distances in this just because I'm a lot stronger than I used to be, but the platform is fairly narrow. There's no sidewalls or anything like that, but the midsole is fairly soft. It feels very similar to almost like the New Balance Fuel Cell, the RC Elite 3 or 4. It's got that kind of feel. It's not as aggressively fast. It's still comfortable. It can still move. I use it for a lot of workouts, but it feels more comfortable. Like it would work better for someone with neutral mechanics, especially like a recreation runner just getting into the stuff who's got some cash to burn because it's $300,
right?
Which that cost is insane, but it's also pretty narrow. So not narrow, but like snug. So people with narrower feet or want a narrower platform.
Not narrow on the outsole, like connection to the ground, as much as you meant narrow upper.
Yeah, both actually. Like the actual width of the shoe and the upper are just a little bit more narrow, which has been fine, but like for shorter distances, but wouldn't be my choice for longer races where it would probably actually do best based on the foam responsiveness. So it's like, it's not in your tier 1 category. It's more of like, the durability is actually pretty decent. I've got like 40-ish miles on my pair and I still haven't ripped the outsole off completely, which is great, that's a big deal.
That's surprising too, with how the shorter cut on that lateral side, usually that's where you rip it off too.
Yes. So. I mean, give me another run or two. We'll see. But, yeah, I think it's like somebody combined the Saucony Endorphin Speed and Pro almost, where it's like, yes, this could totally be a great speed trainer for people that want a really comfortable shoe, but it can get aggressive if you want. It's not really in either camp. It's in this kind of interesting middle ground for sure.
Yeah. Very cool.
Yeah.
Also, I don't know why this popped into my head. What's your perspective on grape flavored candy or grape flavored items in general?
Can I get to the punchline on this really quick?
Maybe. I don't know. Yeah. Is it are you a joke punchline or you know where I'm going with this?
I know where you're going with this.
Okay. Yeah. Go ahead. Yeah.
So like shout out to Scratch Labs. They're really kind and they send us stuff like to test out. So they just sent us their new grape flavored chews, which how do I say this? I really like the chews, and they are a bit expensive, but I really, really, really like them, especially from Scratch Labs, because they do this. It tastes really good. They got the little like crystalline thing on the outside. It's just, they melt really nicely in your mouth. They're always really great. But yeah, grape isn't usually something I'm going to reach for. It's not on the top of my list of like, these were actually really good. I'm really enjoying them. Yeah, for sure.
They're mild enough where it's not like, what's this Concord grape doing in my stomach when I'm trying to run right now?
No, I've taken it as a like snack throughout the day. I've done it on run. And kudos to Scratch. And this is like, I know that they like send us some stuff and it's really, really nice, but those chews dissolve so nicely on run. Like I feel like chews for me is like a hit or miss. Like I'll do that pre-run, not usually during run, but it just dissolves very nicely. Never had an upset stomach. And I'm like, my stomach's a bit of a princess, like, and the pea kind of thing. So
nice.
It was I've really enjoyed it. And the grape is pretty mild. It's great.
Sweet. Well, let's get into what we really care about talking about today, which is IT band syndrome, iliotibial tract. And IT band syndrome, we're going to get into definitions later and causes and all that kind of stuff. But this condition is one that affects a lot of runners. It's usually near the top of systematic reviews that look at the types of running related injuries that runners most commonly get. About 12 to 16% of runners have gotten IT band syndrome at some point, or that's the prevalence that happens. You've had it. I know I've had it. It was the thing that was the bane of my existence for my first marathon when I did Chicago back in 2017, I think was my first one. So it's something that many people have dealt with, or people are like, I know it exists. What the heck can I do to have it not happen to me? But before we get into more about the syndrome itself, do you want to give us a rundown and basic overview of the anatomy of the IT band?
Yep. So the anatomy of this thing, and for those who don't know, it's kind of ironically, it's one of the things that actually makes us uniquely human, is that it's this long band, and they kind of argue as to what exactly it is, whether it's fascia, whether it's connective tissue, whether it's an extended tendon. You talk to different anatomists, they're going to argue on this stuff, but it's basically this tissue that goes from the lateral aspect of your hip, or the outside part of your hip, and the two places it originates from are your iliotibial tract, your tensor fascial lata, which is a small hip flexor, hip abductor on the front of your hip, front lateral aspect of your hip, and actually your glute max, that big hip muscle in the back, the most external one. Those two muscles come together, and some of their tendons and some of their attachments actually come and become the iliotibial band that continues down all the way down the side of your leg, all the way into this really cool area called Gerdy's tubercle, which is on the lateral aspect of your knee. And the purpose of this thing is actually to help facilitate upright gait. And it's one of these things that allows us to actually spend more time up there. It's a long thing. There's a really long lever arm. Really, it does help to some degree with a level of knee control, a little bit of hip. And it's another area that helps connect the hip and the knee. Those areas are very, very related. Now, it's this long connective tissue. The IT band itself, this is really important for later. That thing does not contract. It can get pulled on, but the muscles are the things that contract. So the tensor fascial lata up higher, the glute max, those things contract. The iliotibial band does not contract. And I will tell you, and I'm sure Nathan might be able to say this from being in a cadaver lab, if you try to stretch that thing, it doesn't really stretch. It's pretty thick and it's pretty stiff. It's a wonderful tissue that will really pull nicely, create some lateral stability on the lateral side of the body. It does not stretch. However, there are some places where it can commonly get really irritated. There are several bursa that sit right under it. So there's one that sit right under it at that outside part of the hip, at what's called the greater trochanter, and there's the lateral bursa right there. And these are these fluid-filled sacs that help this tissue slide over these bony prominences. There is also one farther down in the lateral knee. And these are suggested sometimes to occasionally be symptom sources for iliotibial syndrome. And other times it might actually be nerves or the insertion itself. So that's the quick overview of some of the tissue. Anything you would add on that?
I think the only thing I'd add is some of the diversified attachment at the knee. So as you said, it goes from the hip down to the outside of the knee and attaches primarily into Gerdy's tubercle, which is part of the tibia, which is kind of your main shin bone. Like if you knock on your shin, that's your tibia. It's attaching into there. But the IT band also kind of fans out. So part of it will go into your kneecap, into your patella. Part of it might go down to the fibular head. Part is going to go into the joint capsule. It does fan out, and that's why sometimes symptom presentations can be a little bit varied between people, depending on which area is irritated or where extra pressure is going. The other part of the anatomy that I think is interesting and contested in some ways is, and this kind of brings us into our discussion regarding the syndrome itself, but is how it interacts with your femur, that long thigh bone. So as it's coming down the outside, it crosses over what's called the lateral epicondyle, which is kind of a bony prominence on the outside of your thigh bone. And there is some cadaveric evidence that the IT band actually has solid attachments to the lateral epicondyle, which would mean that the pain that can come from it is not from friction rubbing over, but due to compression over the structures underneath it. The other side of the coin says it doesn't have solid attachments there. And when you bend and extend your knee, the IT band kind of flips over and back across this external bone. And that friction can cause some of the irritation to the IT band or the underlying structures. So I think that's another important part, is how it goes across the outside of the knee and that interaction with the femur. What you got, Matt?
And I will say that probably whenever I hear that, so some people might get really confused and go, oh, okay, well, I guess nothing matters then. I'm going to disagree with that. That I think when you hear that kind of stuff, both are probably true.
Right.
And you have to realize this is the variety that you see with human anatomy, that sometimes you'll have this certain muscles, certain things that'll attach some odd places sometimes, that it's not perfect. So there are probably different and anatomical variances in people, and some people might get more compressive, tension, like
Friction.
twisting, friction, what have you. So no, that's why as we talk about this, there's going to be some variety of experiences there, probably because everybody's anatomy is a little bit different.
I would say, just to bounce off of that as an exemplar of anatomical variability, when we were doing a cadaveric dissection during PT school, we were looking at the relationship. So, well, I'll back up for a second. Many people have heard of the term, quote, piriformis syndrome. And part of the theory behind piriformis syndrome, I'm not putting any sort of weight on the words I'm about to say just for the sake of the analogy or the example, is that the piriformis is very closely related to your sciatic nerve. They run very close to each other. And in our cadaver lab, some of people's sciatic nerves passed underneath the piriformis, some of them passed over the piriformis, and some of them went through the piriformis. We had all three variations in our cadaver lab. So when we talk about variations at the knee, disagreements between different studies that look at cadavers for evidence of the attachments to the IT band, it's just true. We're all different and we have variability. I think when it comes to the management treatment understanding, it doesn't necessarily change anything too much. So don't get too hung up on it. But I think it's an important thing from conceptualizing what's going on, because as Matt said, this is an extremely thick tissue. It is not one that you would be able to stretch by any means that we have, like you would stretch your hamstring or your quadriceps muscles or whatever. We do not have the tensile loading to put through the IT band that would actually cause tissue length changes of the IT band. But before we go any further, I'm just going to quickly talk about what we're zeroing in our conversation on. When we talk about IT band syndrome, we're primarily talking about when somebody is presenting with pain on the outside of their knee. So we can get pain up in the hip. We're going to be focusing our conversation down at the knee. And it usually is sharp in nature. It usually comes on with a predictable amount of stress or strain on that tissue. So if you notice that every time when I run, when I get to mile 2, I start to notice that the outside of my knee hurts, and then it goes from dull to sharp, sometimes relatively quickly. That's what we are referring to, is this kind of sharp outside of the knee pain. Sometimes this is also called, quote, runner's knee. But again, as David and I talked about a few weeks ago, runner's knee is an umbrella term applied to a lot of different places. You're going to say something.
Yeah, I was going to say that this is usually different than, like, this is my argument. This is not a tendon that some people have. It's like, so tendons, oftentimes when you have a tendinopathy, you'll have this thing called a warm-up phenomenon where it'll kind of ache as you start, and then it gets better. And then it can get really bad after you finish. The IT band stuff, from my experience, has been usually like you start out okay, and then it gets worse. Like it transitions from like kind of achy, like you said, then it gets worse and worse. There are some things that in some people can actually hold that off, and you might be able to do a certain thing, and then it allows you to continue on. But generally, it gets worse as you go on. Typical kind of presentation, not like, oh, it starts off really bad and then warms up.
It's better.
Yeah.
And I think the other difference with a tendon is elasticity. Tendons have a pretty decent amount of elastin in them, which allows them to stretch. This thing doesn't have that elasticity. There is, as we just talked about, there's variation regarding how much mobility someone's IT band may have. And again, that's not something that we have control over in ourselves or in terms of what we do in rehab. It's just kind of a reality for you, and it may not even be testable. So again, we don't need to belabor that too much, but we're all a little bit different. So let's talk a little bit about what we know about risk factors for this. What types of groups of runners, what sort of people, what sort of things do people do or partake in that put them at risk for developing IT band syndrome?
Right. And there is, again, we're going to go say the same thing you've heard, and it's not to confuse you, it's just to be honest with you, that there is some conflicting research on what we're about to say. So some of the current systematic reviews and meta-analyses that have been out there now have been like, oh, if you are a female runner, that there are certain biomechanical risk factors like increased peak hip adduction, meaning your femur is coming inwards or your hip is going this direction. There's some suggestion that hip abductor, or the muscles on the side of your hip, that weakness there may predispose you to risk factors there. It's not as clear cut for male runners, although there is some evidence that there might be some similar risk factors there, but those are also some factors that might be things to look at. Some people suggest that maybe if your femur, again, that long bone that connects to your hip, if that rotates inwards, you get some internal rotation, that might be a risk factor there. And there's also some things on the hip. But some of the big things I look for, even though the research is a little conflicting, is going, hey, is there any kind of motions that might stress it, right? So I'm looking at frontal plane, like side to side. Is there any kind of weird motions where people are going either a little bit too far in or a little bit even too far out? I'm looking at what the muscles that attach there. Do you have good control of that? So you have adequate functional performance of those. The IT band, or not the AT, the tensor fasciae lata, even though it's not necessarily attached there, the glute med, the glute max, like, do you have good functional control of those, or are those irritated? And then finally, I'm also looking at, hey, rotation. Do you have good rotation of the pelvis, of the femur? And then I can move from there usually. Anything you would add to that?
I think when it comes down to any injury risk, there's the baseline levels of predisposing your body to any sort of injury. So is there increased stress in your life, decreased sleep, poor nutrition? And I'm going to harp on that every single time we talk about injuries, because it really matters. You could have, as I mentioned before, you can have the same volume of running for 20 years, and then you have a kid, and then your sleep is less and you do the same amount of running and you end up getting hurt. And that's not because your running volume has changed, but other factors. So holistic picture of, are there changes in my life that could predispose you? Yes. Poor sleep, poor nutrition, all those kinds of things.
Right. Then even overtraining, things like that, which probably explains the inconsistency in the research going, this is multifactorial. So keep going. Sorry.
That's where I was going next, was I think the next thing that can predispose you to this is a significant and rapid increase in your training, whether that's volume or whether that's duration of running or miles, or if you're looking at a lot of new speed work or running on hills. There's some thought that from an environmental factor, if you run out in the country on cambered roads that have a slope to them, it can predispose one or the other knee, depending on who you are, to IT band syndrome on either the one that's on the bottom side of the slope or the one that's on the top side of the slope. I was going to also bring up differences in anatomical shape that sometimes follow sex differences. They found that more often men who have IT band syndrome run with what's called knee varus, meaning that your thigh comes down and then your shin starts to come in. So your knee kind of is knock-kneed. Whereas women who typically have IT band syndrome have knee valgus, which is that hip adduction where your thigh is coming in and your knees are, did I say knock-kneed? Bow-legged, I meant to say for men. Sorry, knock-kneed for women. Apologies on that. Yep. So I think that's another one of those differences between people, because what really matters, I think, when it comes to understanding why you in particular may have IT band syndrome is, what is the thing that's causing more stress to the IT band down at the knee that you could maybe mitigate or take care of? And they found that your running gait actually plays a potentially pretty big role in that. So more than many other conditions, I think gait assessment and potentially gait retraining, whether temporary or long-term, plays a bigger role in this than it does some other conditions. And this might just be my perspective. But I think part of it is because there isn't a lot of other tissues connecting to the IT band. You can't just like do a tendon loading program like you can for the Achilles. You can't just do quad and hip strengthening like you can for patellofemoral pain. And we talked a lot more about other things you would do with that too. So I think looking at mechanics and understanding what is predisposing you to more stress and strain on the IT band. So you mentioned a lot of them. If you are having increased motion of the thigh inward while you're in that stance phase, that is stretching the two muscles that Matt said attached to the IT band, your TFL and your glute max. If you internally rotate, that also puts stretch on your glute max. If you are having knee varus, you are stretching the IT band across, not stretching, but you're putting tension through the IT band at the level of the knee. If you have hip drop, so if your opposite hip is dropping down, that's putting stretch through the TFL and the glute max. Any of those mechanics can increase amount of load down at the knee and potentially be part of the reason why you're getting that increased stress, which can lead to that pain. I think I'm done talking. Wait, one more. One or two more. One of them is crossover as well. So if you're somebody who has a very like weaving gait, very narrow foot placement, biomechanical studies that are looking at correlations between people with and without IT band syndrome, they usually have a more narrow running gait with their feet closer together, or they have that crossover. And then the last one that has been looked at as well is the amount of foot pronation. We are very careful on this podcast and as doctors of running to not demonize pronation because it's a very good part of this, but there is a kinetic chain connection where if you have a more pronation of your foot, that's going to lead to rotation likely at your hip going inwards as well, which we had said also can increase strain on the IT band. So for me, a big thing is looking at mechanics. What are the mechanics that you're presenting with that can increase stress or strain on the IT band? And then working on how do we fix this? And we'll get to that in a second too. What were you going to say?
I was going to say that yes, pronation certainly plays a factor because it might kinetic chain wise drive some things inwards. The same can be said of going the opposite way. And so if you get driven a little bit too far outwards, that's going to take the same way. So I feel like IT band syndrome is a lot about, okay, how are people moving? Are they going to either extreme? Because the body extremes are okay if your body's accommodated and that's just how you're made up. But typically things tend to operate a little bit better being in a bit more of a middle position, and middle will vary depending on the human being. But this is one who's like, don't go to the extremes. You want to have good control in the middle. You want to have adequate strength. You want to have, you can see motion. You just need to have control over those things. Like, so the goal is not to necessarily totally stop things, but it's going, how do we give you a bit more movement control over these things? And maybe they don't happen as fast and you don't have to get as much tensile compression or friction load that you can't control. So it's, can you improve the quality of the movement? And that's why I totally agree with you. Looking at gait analysis is really good to go, what's the quality of this movement? Not just quantity, but quality wise, what's it look like?
Right. I think something that's also tricky with this one is a little bit of a paradox because a lot of times the answer to a lot of things is, well, do some strengthening and get stronger and strengthen the muscles that help control this motion. The muscles that help control the motion are also the ones that put tension through the IT band, for namely your glute max. And so if you're training your glute max for max strength, every time you contract your glute max, you're also putting a pull through the IT band, which could lead to compression at the outside of the knee. And so there is this weird balance of figuring out what type of strength training is important. And is it truly max strengthening or is it something different? So what's your perspective on how strengthening and IT band syndrome come together?
Yeah, the first piece of this is, and I don't know if we've talked about this before, but like tissue healing timeline. So like if you just injured this thing, doing a ton of strengthening may not be the best option in that early phase of healing because the tissue's not ready to get loading. If things are still irritated, a little inflamed, and I know there's conflict on like, is inflammation good or not? We're not going to go there. But when things are really acutely irritated, doing a ton of strength work right then isn't the best thing. Like your goal at that point is, let's calm this down. Let's get some movement in there. If you can run, great. If not, it might be best to let this calm down. That early phase is not when loading is or at least not heavy strength training, maybe the most appropriate thing. But as things calm down, then yes, strengthening may be part of what you need, but it really depends on what type of, and I'm going to move away from strengthening to say, what kind of loading do you need? Is this an endurance problem? Is it a strength problem? Is it a power problem? And when your symptoms show up, will kind of guide you from a rehab perspective of what you need. Like if you're someone who's like, yeah, I'm totally fine for like 8 to 10 miles. And all of a sudden at that point, that's when I start to feel it. That, assuming some testing, might be more of an endurance problem. If you're someone who goes, yeah, I get this more when I'm like either on hills or I'm like having to produce more force, that might be something that might guide your PT or whoever it is to go, you know what, maybe we need to look at strength. So make sure that you pay attention to your symptoms and go, okay, let me make sure I match this. But some level of muscle performance is probably going to be helpful, but what type is really, really key to think about. And then also when, making sure that is the environment of the IT band ready to be loaded is really key. Because a lot of people will jump right into strength stuff. And it's like, oh, it's making it worse. I'm like, yeah, because it's not ready to get loaded yet. You have to wait and let things have the tissue be ready for that.
Right. And what I think is really there's a lot of complexity here, but I think what is really interesting is that loading of any tissue is good. We're not necessarily talking about, can I run through IT band syndrome right now? But usually for any sort of soft tissue thing, complete rest is not the answer. Complete rest leads to poor healing over time, because if it doesn't get a stimulus, it's not going to respond to the stimulus in a way that makes it more robust for that movement. So in general, some sort of loading is good, which is why, although strengthening may put more tension through it, maybe that's the amount of tension you need to help healing it. Finding that balance is tricky. I think the other thing that I think about when I'm working with people with IT band syndrome, got a couple of them in our running clinic right now, actually, is not let's get you as strong as possible. It's let's learn how to use the strength you have or get the strength necessary to change your movement. Matt and I met at a course with Dr. Chris Powers, and I remember him saying several times that weakness doesn't cause pain. It's movements that happen due to weakness can put increased stress or strain on a tissue that can cause pain. So does the person have a weakness? Yes. Does that result in the movement impairment that would be associated with that weakness? Maybe or maybe not. If yes, then yes, you got to strengthen so that you can change the way you move potentially. Or no, they have full strength. They're weak, but they're moving just fine. Then your exercises are going to be targeted towards neuromuscular retraining, learning how to walk, do stairs, or run in ways that decrease the amount of stress or strain on the IT band. And so to say kind of two things, it's you might not do heavy strengthening, but you probably should do some sort of neuromuscular control depending on what your movements are. Again, you need to have them assessed. And then the second thing is to always be doing something. Complete rest is probably not your answer for long. If it's a day or two, sure, but you probably should have some sort of loading going through this so that you don't run into a long chronic situation where you're having worsening condition of the IT band. So the next thing I want to actually talk about is probably what people most commonly hear and do. And it's, okay, you've got pain on the outside of your knee, you better foam roll and you better ice and you better rest. What's your perspective on soft tissue massage of any kind to the IT band or in management of IT band syndrome and icing and rest and things like that?
Yep. So I'll be very honest that when you try to foam roll, do any kind of soft tissue mobilization of the IT band, you're not going to change the tissue. You're not breaking up adhesions. You're not, there's lots of data to suggest that is not what's happening. Does it make some people feel better? Yeah. Do we understand totally why? There's some suspicion that you're stimulating some of the, what's called cutaneous receptors or mechanic receptors, i.e. the specific nerves that are responsive for like pressure into the skin. Maybe you're stimulating those, and that might, in some population, provide some relief. I would be more likely to go, if you are someone that responds well to soft tissue stuff, I'd honestly do it on the tissues that actually changed, which is the muscles up higher. So glute max, tensor fasciae lata. I am much less likely to suggest doing that over the IT band, because that's just tissue. Like if you're going to be doing soft tissue mobilization, the mechanisms by which that is supposed to do something is not really going to affect this tissue very well. And we know that it's not breaking up adhesions or doing any of those things. Does it provide some potentially pain relief because you're actually stimulating your brain and some of your peripheral nervous system? Yeah, that's a real thing, right? I was telling Nathan, we were at combined sections meeting, and I went to a guy whose name is Adrian Lau, who's like one of the really good like pain and chronic pain researchers. And it's ironic because I'm teaching modalities right now. So I'm teaching massage, ice, and stuff like that as someone who's like,
me too.
Very, yeah. Oh, that's right. We both teach this. So it's like, we're in a situation where like modalities by themselves is never something that should be used. Like it should be in conjunction. And then a lot of the evidence is not very good. But then, hearing him say, you know what, you can't ignore this stuff because pain is not just in your brain. There's multiple components that go into this. So I would say if you are going to foam roll or do soft tissue stuff, I would do it proximally on the muscles that influence this. I think that's going to be more effective. From a icing thing, there's also some good evidence that icing actually really affects your nervous system. And some people may do super well with that. but it's honestly going to be something that there's a very small window of time where that might be effective. And it's usually very early on. Later, what's probably going to be like, if you just injured it, if you respond really well to ice, awesome, go to town. If you don't, you hate it, don't do it, right? If you respond really well to soft tissue, massage or foam rolling, I would suggest doing it up like proximally closer in the hip where those muscles are. If you don't, great. And that's going to work well earlier on and maybe reducing some tension. But at some point, you got to get as quickly as you can to the appropriate loading or the appropriate movement. So in small dosages with active motion, fine, great. I'm not going to say no, but long-term, that's not going to fix this.
Yeah. I think that where people fall short, and this includes myself and tons of good friends, so this is not an indictment on people without myself being involved, foam rolling shouldn't be your mainstay treatment. It can be part of it, as you said, for pain management and management of some of the other soft tissues that may be holding tension, which can again increase the amount of tension on the IT band, which can increase the compression on that area. Yeah, great. Let's relieve some of that, cause some short-term changes in symptoms. There's nothing wrong with that, but it can't be your mainstay treatment to actually solve the problem. The other thing we didn't talk about anatomically is that because it's this band and it kind of has this spanning nature, it does also have relationships with one of your quad muscles, the vastus lateralis, as well as with one of your hamstring muscles, the biceps femoris. And so doing soft tissue work to those areas as well is also something that wouldn't be a bad idea. Instead of going directly over the IT band, work on the things that can actually change. So I would recommend those two things as well. What were you going to say?
I was going to say from a differential diagnosis thing, because I've seen this actually several times. Speaking of things that are around that, there's something called your lateral femoral cutaneous nerve that travels all along the outside of your hip. And nerves like three things. They like blood, space, and movement. And sometimes when you really compress those things with like a foam roller, if it's lateral femoral cutaneous nerve syndrome, that often doesn't respond really well. And it's kind of one of the reasons, not that I'm saying it's all that, but in that area, I kind of leave that, like I don't tend to push in that area too much. Like Nathan said, I'd rather actually work on the soft tissue structures in the area. And it's not to scare you. If you respond really well to foam rolling in that area and it helps modulate your symptoms, awesome. Just please do something active, not just passive. But yeah, I would say stick to doing soft tissue techniques to the muscles and not to like tissues like this.
Great.
Just for like efficiency. Like if you're going to do this, that's where you're going to have probably a larger impact. Right. And it's a solid management technique, either using a foam roller, the common thing, like this will happen to Regina all the time. So like my wife, who's a pro runner, will be out in a run. And then like during the warm up, like after 2 miles, she's like, oh yeah, by the way, this hurts. I'm like, I know what this is. Awkward. If you ever see us on the road and I've got like caressed my wife's hip and I've got my thumb jammed into the front of her, like a front outside of her hip, I'm just like digging into her tensor fasciae lata and trying to change the tone. And then I was like, usually takes one time, a little bit of hip muscle isometric stuff, and she's fine. I'm like, yeah, you're not doing your hip exercises. Cool. So do that when you get home. Right. But that can change tone. It's really great. It can, doing like a TFL stretch sometimes can reduce tone. It can be helpful for people to keep running. But all these things, should not be your main treatment. They are going to be, Nathan, what's the term I'm looking for? They are short-term symptom modification, but not symptom elimination or problem elimination.
Totally. So there's a couple more topics that I think we should cover. I can hit one of them relatively briefly. It's how long is this going to take? If I have IT band syndrome, how long is this going to take? Unfortunately, the answer is it is extremely varied depending on the level of irritability and the potential causes. Some people are going to get IT band syndrome. They're going to catch it early. They're going to do a couple quick modifications to their training, and it could be gone in 2 to 4 weeks. Unfortunately, for some folks, whether it's because, they're in the middle of a marathon training block and they're just going to push through it no matter what, I'm pointing to myself, they're going to have this linger the entire rest of that training cycle, maybe 10 weeks. And then it's going to like bug them afterward. For me, it was for several months after my marathon still, I was dealing with this. And it required modification to my training during that entire thing. So it can be anywhere from very short to quite a long recovery, even up to a year for folks that I've worked with. Unfortunately, it can stick around. So then I think the next question is, what sort of recommendations do you have for how much pain is acceptable? Is pain acceptable at all? Should I run at all?
That's a very good question. And the reason that this might be even the most important part of what we talk about today is that like this really plays into like concerns. And we get this as runners going like, wait, like is any pain okay? Can I deal with this? The answer is some symptoms are okay. Like it's okay. Like Nathan mentioned, it's okay to keep moving if your symptoms have a manageable level of irritability. And when I say irritability, I mean how intense do those symptoms get and how quickly do they get there? So if you're someone who's like, and I'm going to use the pain scale, which is not perfect, but it's kind of what we have. If you're, as an example, you're going and running and your symptoms are like an 8, 9, like 10 out of 10, and you cannot modulate them at all, that's not a good reason to be running. Like that is too high. That is going to really change your mechanics. That's going to really alter how you're moving. And that might honestly put stress elsewhere. If it's like a 2 or a 3 out of 10 and it's manageable and you're okay and it doesn't get that much worse, that's probably fine. You still need to pay attention to this and you still have some work to do. But again, it's going to depend on what's tolerable for you and what can handle and then how it progresses. If it suddenly jumps up and it won't go down, you're probably pushing more than you should. If it's staying level and it's that low level, manageable, you're like, I know it's there. I know it's not threatening. It's staying consistent. Then that might suggest you might be able to get away with this. This is very different than something I always think about when we talk about like, oh, it's okay to stay like loading if it's just it's not a bone stress injury, right? It's not like bone stress injury. You have 0 pain. That has to be 0. That is the rule with that. It's not that. You can move through this. Some symptoms will linger. There's a lot of tissues in this area too that can actually potentially be pain generators. And there's even some ones away from that area that might, like fear or fatigue or other like preconceived notions or how you're viewing your body or your stress level can also generate symptoms. Like I have a love-hate relationship with my IT band because I know how to manage it pretty well. Like I'll feel it and go, I just need to be, for me, it's like, I know I need to be doing my hip strengthening stuff. And I'm like, I've been slacking. I deserve this, or I had a sudden jump in training. And I can manage it pretty well. And then like, it'll be fine. And I'll just be sitting there and be stressed out and I'll feel it. Come on. I'm not running. I'm literally sitting down and I'm like, what the heck I'm like, yeah, that's just, I've had this enough that when I start freaking out that I will get some like psychosomatic symptoms in that area. So that is a real thing.
Yeah.
That's my spot. So it's like, I've had a lot of Achilles stuff, but IT band is my go-to. If something's going to happen, it's like, that's what flares up. And it's happened enough that I probably have a couple neurons in my brain that when they get stimulated, I get symptoms, even if I'm not loading the tissue.
No, I think that's great. I am not a physical therapist that tells people to stop running very often. I think that continual load is necessary for proper adaptations to tissues, save bone stress injuries. That's definitely an exception to the rule. So I agree with you that some level of symptoms is fine. I think though there is a threshold that it's like maybe a break from running of some extent, which could change depending on how severe, is necessitated. I think that if you are somebody who is walking and having more than minimal pain, it's probably the irritability is high enough that it's worth taking some time off to allow it to heal faster than it would if you just kept putting that increased strain through it. I think another good sign is if you're having a lot of issues with stairs. If you can't handle stairs and you can't handle walking, you probably aren't ready for running. And when I say handle them, again, I mean minimal pain, 1, 2 out of 10. And so you should be able to do like 30 minutes of walking, and then you should be ready to go on a run and try that out. And then I'm with you on like the pain scale, kind of shadowing the pain monitoring model for Achilles. Anywhere from 0 to 3 is going to be very much in the safe zone, dull. And then, 4 to 5 is still going to be acceptable. It's giving it a stimulus that it should adapt to. But I think if you don't like the numbers, I like to say if it goes from this dull pain to anything that you could determine as sharp, that's beyond the threshold that's beneficial for the IT band at that time. And then any sort of soreness that you had should resolve by the next day. You should wake up the next day and not be wondering, oh, is that still there? Oh, that feels worse, or that feels like it hasn't calmed back down. You're trying to like play this line where you're letting the symptoms decrease sequentially over time. And if you're just doing the thing to bump it up a little bit more each time, you're just setting yourself on a long recovery path. So there is not a perfect course, not a perfect amount of running. It's you figuring out what does it feel like when I go on a 30-minute easy run? Does that increase my symptoms above something like a 3 or into that sharp zone? No. Great. Does it calm down by the next day? Yes. Okay. This seems like an acceptable amount of discomfort that I'm going to keep moving forward, because that stimulus that causes discomfort is also going to promote, hopefully, positive healing in the tissue itself. So the last question that we want to talk about is this question of shoes, because we're on the Doctors of Running podcast. We have to talk about shoes. Do you think that there are any shoes that are ideal for people with IT band syndrome?
Ooh, that's a great question. So I was talking to Nathan about this beforehand. I'm like, they're going to hate us for this. I'm going to try not to give this like, oh, whatever works for you. I think you need to address if there's any risk factors that a shoe can modulate, then that's what you need to think about. And I'm going to use myself as a case study, and then we're going to expand on that and say how other people might be a little different. So I am someone that needs at least a mild level of guidance. That might be from a stable neutral shoe. That might be from some medial support. I just need a little bit there. If I go too far, that actually will take me the opposite direction. So every time, and thank you, Brooks, for sending this shoe. Every time they send us the Brooks Beast, which is the like one of the few true motion control shoes left on the market, I know that to get miles on this shoe, I'm going to piss my IT band off. It is just too stiff for me. There's too many stability features, and it's going to drive me in a way that's going to bother me. And for some people, that's actually going to be their Goldilocks shoe. So you need to make sure you have adequate support or stability for you. And that might be in a pure neutral shoe, because some people, you put them in a stability shoe and it starts driving them one direction, that knee might go with them and they're not going to like that. So for me, I find that perfect level keeps me in the middle. So that's actually something, ironically, with the Gara Carbon 2 that we've been talking about. Because the platform's too narrow, I know as I take this up to higher mileage, I start to feel my IT band a little bit, because the platform's narrow. There's not really any stability mechanisms that I typically need. If I keep shorter, I'm fine. But narrower platform, no structure, like there is some stiffness, but it's still, mostly in one plate, the front to back. I know it's going to get irritated. So too unstable, not going to work really, really well. Too stiff and stable, it's also going to be too much for me. So that's where, for me personally, shoes like stable neutral shoes are great. That's why I think I'm working so well with the Cumulus, as it's got not the narrowest midfoot. There's some other features that make it stable, but here's some things you need to think about. You need it to be stable enough. So if you have some stability needs, you might need that. Okay. If you don't, you should be avoiding anything that's stable, because that's going to irritate that structure might bother you more. The other thing that might be irritable is I have found that super soft shoes typically don't do well. So like moderate, like slightly firm, or like fairly in the middle with that tend to do very well, because I get good proprioceptive impact feedback and I don't feel like I'm like collapsing one way. This is why, like, not to poo-poo on this shoe, the Neo Zen and I did not get along. It was just too soft. I felt like I was going all over the place. And as I went up to higher mileage, I'm like, yep, I can feel my IT band start to tighten up a little bit. And that's going to vary.
I'm enjoying it right now.
Yeah, I knew Nathan's loving it, right? So this shoe is just too soft for me. So for me personally, when I land on this, I get too wobbly, and then I can feel my mechanics kind of like I'm either stiffening up too much and holding too much tension, or moving too much. So typically really soft shoes may not be the best option. So, but firmer also might be a little bit too much. So I have found, for me personally, stable neutral shoes are that nice middle ground, not having too much sole flare, because I've also found that if the sole extends too far out and I hit it and it drives me inwards, that can be irritable. So just finding that Goldilocks fit of like, and maybe a little bit more rocker so it moves you forward rather than side to side can be helpful. But this is going to be unique to you. And that whole run cat thing is like really important, finding what works for you, what's stable enough, what is just feels right underfoot.
Right. Yeah, I have had experiences with this too. And actually, I'm blanking on the name of the shoe. It probably would have been in 2019. Okay. And it was from 361. It was it was their mild stability shoe at the time. They don't make this model anymore. I tried to Google it while you were talking.
I'm gonna go look this up. I know what you're talking about.
But I'm a person where my running gait is kind of straight line from my hip down to my ankle, or I have a slightly bow-legged position. And so if I'm in a shoe that has a medial post, I kind of bend outwards a little bit, which increases stress on the outside of my knee. What's it called? Did you find it?
Is it the sensation?
Yes. Yes. So I got the sensation. I remember the run. It was a 5-mile run that I go through Schmeekley Reserve in town.
I remember this too.
2.5 miles in, and I was like, crap. So I had to like walk, because I was like, I'm not going to push this. So for me, it's those posted shoes that keep me a little bit up the chain for me does something enough to change it. So I think there is that Goldilocks phenomena with finding a shoe. If you're a person that's having kind of that hip adduction positioning, you probably want something that would facilitate, in theory. I'm very hesitant to like connect knee mechanics to foot to shoe mechanics because they don't
always match.
So know that we're saying this loosely, but if you are one of those people, you'd probably want something with a little bit more structure, as Matt is saying, like a stable neutral thing. Whereas if you're someone like me, where you're a little bit more knee varus, you probably want something much more neutral that's going to allow you to, versus even stable neutral, less sole flaring, as you were saying, except my sole flaring issue is when it's on the inside, then it like keeps me out. Good. So I think that's that Goldilocks phenomena. It depends on what your mechanics are going to dictate what shoe might be a good option for you. Whether or not it's worth buying a new shoe because of IT band syndrome, I'm not ready to go there. But if you have multiple shoes to choose from, that's how I would conceive it. Yeah.
Yeah. That's actually what I would say is if you have a rotation of shoes, this does not necessitate buying a new shoe, right? Because it's kind of like foam rolling, like going through that's not what's going to fix this. It's making sure that you figure out, like, are you overtraining? Is there some kind of movement or muscle weakness thing that you got to deal with? Like, that's the real answer. But if you have a variety of shoes, staying away from extremes is probably going to be better, or knowing what you typically tend to work better in is going to go that direction. Like, for example, I think super shoes are typically not a great option for this because they tend to be really stiff, but also super soft and unstable. That is a group I would probably stay away from versus like your trainer that works for you, that gives you either the guidance you need or it doesn't overcorrect you. That's the shoe you probably want to spend more time in as this gets better, and then slowly ease your way into shoes that maybe are like a teeny bit outside of that comfort zone.
Great. Well, thank you everyone for joining us on this journey where we talked about IT band syndrome. If you have other questions about IT band syndrome, or things that you found that you have worked well, or things you've learned from your physical therapist, you can drop those in a comment. And we're excited to continue this conversation and other ones. If there are other conditions you'd like us to cover, we have a number of these types of episodes that we've done over the years, but they can always do a refresh and kind of revisit with new things that have come out in the literature. So if there are specific topics you would like us to talk about, you can either email us at doctorsofrunning@gmail.com, or you can comment below if you're watching on YouTube. Matt, what you got?
And yes, we've seen the 1,000 emails about plantar fasciitis. We will get to that one.
Yes, we will.
I know. We've heard it before the 40,000 comment. Plantar fasciitis, we know. We're working on it.
Yes.
And that was the hardest one of all these to do. Do you think it depends on this one? Wait till we get there.
Yeah,
I know.
It's tricky. There's just so much going on, but that's not what this is about. Yep. Thank you, everybody. We'll talk to you next time.